Good morning, class. Today we'll be talking about an important condition called as stridor. Now, what is stridor? Let us hear this. Let us see this video. Now, what do you mean by stridor? It is a creaking sound. So, how it is made? It is an abnormal, harsh, high-pitched musical breathing sound caused by turbulent airflow through the narrowed passage due to partial obstruction in the larynx or the tracheobronchial tree, usually associated with dyspnea. Now, stridor may be heard during inspiration or during expiration or during both the phases of inspiration and expiration. So the types of stridor have been divided with the probable site of obstruction. So the inspiratory stridor, that is the sound produced during inspiratory phase, is due to causes of narrowing caused at the level of pharynx or the supraglottic level. The expiratory stridor is due to narrowing in the thoracic trachea and the bronchi. The biphasic stridor is due to narrowing in the glottic area, subglottic area, or the cervical trachea. Now, this is how, depending on the site of narrowing, the stridor can be classified as inspiratory, biphasic, and expiratory. Understanding it again, the inspiratory stridor, it is because of obstruction, the lesions causing obstruction at the level of supraglottic or pharynx. That is, for example, the congenital conditions like laryngomalacia or inflammatory conditions like retropharyngeal abscess. Expiratory stridor is produced by the lesions of thoracic trachea, primary or secondary bronchi, and the examples of such type of expiratory stridor are bronchial foreign body and tracheal stenosis. Now the biphasic stridor is seen in lesions of glottis, subglottis and cervical trachea. The examples of this type of biphasic stridor is laryngeal papillomas, vocal cord paralysis and subglottic stenosis. A word about stertor. Now, what is stertor? Stertor is it is a snoring, low-pitched, noisy sound due to obstruction in the nasopharynx and oropharynx. And what are rales and crepitations? These are the sound produced in the bronchial tree and alveoli. That is the distal or the peripheral area of the tertiary bronchioles and the alveoli. The severity of the stridor may be understood by the degrees. It is a mild stridor or a moderate stridor or a severe stridor. The mild stridor is only on deep breathing and unusual exertion. A moderate stridor is heard on minimal exertion and the patient is unable to do day-to-day work. When the stridor is severe, there is stridor at rest, the accessory muscles are active, there is tachycardia, the patient has got tachypnea, the respiratory rate is high, heart rate is high, hypoxia is there, oxygen saturation may be low, patient may be having cyanosis, restlessness, and irritability. The video you saw in the beginning of the lecture, that was demonstrating a severe respiratory stridor. Now let us understand few causes of stridor in adult. They can be read under the headings of it can be of infection, it can be due to neoplasm, it can be due to trauma, it may be due to allergy or obstructive sleep apnea. Infections in adults, maybe most common infections are Ludwig's angina and peritonsillar abscess. Neoplasms, it can be malignancy of the larynx, pharynx, upper trachea, tongue, thyroid. So these are the malignancies which may lead to stridor in adults. Trauma, injury to laryngeal trachea, there can be fracture of mandible, maxillofacial injuries, caustic ingestion and radiation burns. They can cause stridor. Allergies, the common allergy causing stridor is angioneurotic and drug allergies. Angioneurotic edema, there is edema of the larynx and various drug allergies. Finally, the obstructive sleep apnea. Coming to causes of stridor in infants and children, it may be classified as acquired or congenital. Among the acquired causes, again, they can be subdivided into causes with afebrile illness and causes associated with fever. In afebrile acquired causes, papillomatosis, laryngeal papillomatosis, juvenile papillomatosis, injury, foreign body, laryngeal edema, adenotonsillar hypertrophy. In febrile causes, epiglottitis, acute laryngitis, laryngotracheitis, diphtheria, retropharyngeal abscess, infectious nucleosis, mononucleosis, and peritonsillar abscess. The congenital causes in infants and children, they are laryngomalacia, laryngeal web, subglottic stenosis, hemangioma, vocal cord paralysis. The various congenital malformations of larynx presenting with stridor also present with cyanosis. There may be feeding difficulties due to choking associated with compromised respiration. The cry may be weak, hoarseness, and dysphonia. The common conditions are, as we have already understood, are laryngomalacia, congenital tracheal, laryngeal web, tracheoesophageal fistula, laryngeal cleft, laryngocele, congenital vocal cord palsy, and congenital subglottic stenosis. Now, how do you assess a patient of stridor? Usually, the impaired airway is associated with dyspnea, the shortness of breath, there is a change in voice, patient may have coughing, there may be local pain, restlessness, there is indrawing of intercostal muscles, suprasternal notch indrawing, and accessory muscles of neck, there is indrawing, and their nasal patency has to be seen. The jaw and tongue size has to be seen, micrognathia or macroglossia, may cause stridor. The severity of the stridor, mild, moderate, or severe. Cyanosis has to be appreciated, it has to be clinically diagnosed, and sequential auscultation of the chest. For assessment, the physical signs of larynx, there has to be history. If it is congenital, then at birth or after few weeks, it may be laryngomalacia. If it is of sudden onset, it can be a foreign body. Progress, if it is rapid, it can be acute epiglottitis. If it is a gradual progress, it can be subglottic hemangioma or a malignancy. There is history of fever. We have to exclude the infective causes. History of cough. It can be due to aspiration or a tracheoesophageal fistula. If there is hoarseness, there could be a vocal cord paralysis or a vocal cord growth. Apnea and cyanosis. There can be bronchomalacia. If there is history of trauma, that could be because of intubation. History of foreign body. Improves in prone position. When the stridor in infant, the stridor improves in prone position. We should suspect laryngomalacia, macroglossia, or micrognathia. When the stridor improves while crying, as the baby opens the mouth and cries, you should suspect bilateral choanal atresia. On the contrary, if it becomes worse on crying or straining, again it may be because of laryngomalacia. Now, how do you investigate these cases of stridor? You have to get the arterial blood gas, oxygen saturation, SpO2 monitoring, X-ray of chest, see the diaphragmatic immobility in the side of foreign body causing obstruction. There is collapse of the lung. If the movement is not there, not seen in one side of the chest. Flexible laryngoscopy may be done. Endoscopy and bronchoscopy. Video fluoroscopy in tracheomalacia. MRI and CT or virtual CT scan can be done to exclude a foreign body. Dynamic MRI in cases of sleep apnea and polysomnography again in cases of obstructive sleep apnea. Now, how do you manage this case of stridor? So initially you have to identify the cause of the stridor in adults and infants, whether it is acquired or congenital or inflammatory or neoplastic or traumatic or drug induced, whatever the cause is identified, you have to treat the cause of stridor. Oxygen administration, if there is hypoxia or cyanosis, humidification, then mucolytics may be administered, parenteral antibiotic in cases of infections, steroids, IV hydrocortisone 100 to 200 milligram bolus, IV fluids, bronchodilators, nebulizers. Patient should be nursed in lateral or prone position, and you have to secure the airway. Now, how do you secure the airway? What are the different techniques? The oral airway, there's a device which is put into the mouth to keep the mouth open and prevent the tongue from falling. That is the oral airway. Then you can do a orotracheal or a nasotracheal or a fiber optic intubation. Laryngeal mask may be used. CPAP may be used for assisted ventilation. Tracheostomy may be done. And in emergency, cricothyrotomy may be done. or a transtracheal needle ventilation may be done. Now, this cricothyrotomy and transtracheal needle ventilation, these are emergency procedures when there is nothing, there is no time for a tracheostomy or a CPAP or laryngeal mask. You can resort to these procedures and save the patient's life. A few words about some conditions causing stridor, laryngomalacia. It is the commonest cause of congenital inspiratory stridor. It is due to excessive softness or weakness of the laryngeal tissues, especially the laryngeal cartilages. Thinning of laryngeal cartilage, which there is a wrinkled and loose edematous mucosa. The epiglottis you can appreciate is omega shaped, and the laryngeal inlet looks like a cruciate, like a cross. You can see this. This is one limb, and this is so it is becomes like a cross, which reduces the laryngeal inlet. Pathology is excessive softening of laryngeal skeletal framework, indrawing of aryepiglottic folds, causing narrowing and stridor. Male-female ratio is 2:1. This is because of low socioeconomic group. Intermittent low-pitch inspiratory stridor develops during first 2 weeks of life. Aggravates on crying, feeding, exertion, and the stridor is relieved in prone position, rest, and sleep. It is seen maximum at the age of 9 to 12 months, and it completely disappears by the age of 5 years. The cry is normal and the voice is normal. In severe cases, there can be feeding difficulty, failure to thrive, and cyanosis. Another condition is tracheoesophageal fistula. There is failure of fusion of lateral furrows, which creates the tracheoesophageal septum. This is the furrow which fails to fuse and develops a abnormal communication between the trachea and the esophagus. Symptoms are barking cough, feeding difficulties, there is choking while feeding, there is cyanosis and aspiration leading to bronchopneumonia. Then comes the congenital vocal cord palsy. This is the second most common laryngeal anomaly after laryngomalacia. 50% are associated with nervous and cardiac systemic anomalies. Infant has a weak cry. There is inspiratory stridor and feeding difficulties. Bilateral palsy more frequent than unilateral vocal cord palsy. In this, the true vocal cords lie in median or paramedian position. Congenital laryngeal web. 75% of these webs are seen in glottis area, that is in between the two vocal cords. Due to incomplete splitting, maybe a thin membranous or thick fibrous web is left behind during the development of the larynx. Mostly it is situated anteriorly. It may be small, very small web over here without causing any symptoms, or it may be a huge web almost covering the entire length of vocal cord, leaving a small air passage near the posterior commissure, causing severe symptoms. Symptoms are hoarseness, stridor, dyspnea or exertion, and signs of respiratory obstruction in severe cases. Ludwig's angina is another condition seen in both infants and adults. Infection of submandibular space involves both aerobes and anaerobes. Alpha hemolytic streptococci, staphylococci, bacterial group. Mostly the source of infection is dental infection or submandibular salivary gland or salivadenitis, injuries of oral mucosa, and fracture of mandible. Clinical features is bilateral wood-like swelling in submandibular, sublingual, and submental spaces, which spreads very rapidly. Skin is tensed and tend to pit and blanch on pressure. Rapidly spreading edema. Patient may exhibit muffled voice. Differentiate between edema of vocal apparatus, double chin appearance, septicemia, high grade fever, malaise, body ache, leukocytosis. There is elevation and protrusion of tongue because of fullness of the ventral aspect of the floor of the mouth, and there is drooling of saliva. This is the classical picture. You can see the open mouth, elevation of floor, protrusion of tongue, the appearance of double chin, and woody swelling hard right from submandibular, submental area. Management is systemic antibiotics, incision or drainage of the abscess. Intraoral infection is localized to sublingual space, and external involves the submaxillary space. Tracheostomy may be required if the airway is endangered. Peritonsillar abscess. It is a collection of pus in the peritonsillar space which lies between the capsule of tonsil and the superior constrictor muscles. Etiology is untreated or complicated acute tonsillitis. Organisms are Aspergillus and Staph aureus. Management is symptoms are fever, malaise, throat pain, reading towards the ST lateral ear, aggravates on swallowing. There is odynophagia, painful swallowing. Patient mouth is partially open. There is drooling. Speech is muffled, also called hot potato voice. There is trismus and restricted neck movements. On examination, the patient looks toxic, febrile. There is tachycardia. BP may be low, and patient is dehydrated. Now, this is the classical picture of a peritonsillar abscess on the right side. On examination, neck movement restricted in severe cases, cervical lymphadenopathy tender and enlarged, jugular digastric nodes are palpable and tender on the ipsilateral side. The Quincy triad is trismus, uvula deviation to the opposite side, and hot potato voice. Another condition is corrosive ingestion, which may cause stridor. Alkali, it can be alkali or ingestion or acid. Both behave differently. Alkalis are cleaning agents, detergents, and bleaching agents. Acids are toilet bowl cleansers, sulfuric, hydrochloric acid, anti-rust compounds, hydrochloric, oxalic, hydrofluoric acid, and swimming pool cleaners, hydrofluoric acids. Now, how do you differentiate between alkali and acids? Alkali, the pH is more than 7. Acid, the pH is less than 7. Alkalis are tasteless, odorless, and consumed usually in a larger amount. Acids are pungent odor and noxious taste. Alkalis cause liquefaction necrosis, direct extension, and deeper injuries, whereas acid burns cause coagulation necrosis and formation of coagulation layer, limited depth of injury. In alkalis, the injury is at the level of esophagus is common, then stomach partially neutralized by gastric acid may result limited injury, and duodenal injury is still less common. In acid, less esophageal injury and more gastric injury. Clinical features, there will be hoarseness, stridor, dyspnea, airway evaluation is necessary, perforation may be there, gastrostomal or back pain is there, localized abdominal tenderness, There will be rebound, rigidity, massive hematomasses may be there. There can be dysphagia, odynophagia, drooling, nausea, vomiting. Management is nil by mouth. You have to keep patient primary in survey. IV fluid administration, gastric acid suppression by intravenous PPI, airway evaluation, and obstruction of clinical signs of perforation. An important topic causing stridor in infants is foreign body inhalations. Children between the age of 1 to 3 are most likely to swallow or breathe in a foreign object, such as coin, marble, pencil, eraser, buttons, beads, or smaller items or food, seeds, etc. may be inhaled. Now, this is a foreign body lodged and impacted in the glottis area. Clinical presentation is choking and coughing present in 95% of cases, presenting with foreign body aspiration. Stridor is commonly present with upper airway or upper tracheal foreign bodies. It indicates prompt intervention. Approximately 50% of children have inspiratory stridor or expiratory wheeze with prolongation of expiratory phase and medium to coarse bronchi. Patients may represent with laryngeal hoarseness, aphonia, stridor, wheezing, coughing, and unilateral wheezing. The management will be endoscopy and removal of the foreign body using rigid bronchoscopy. Post-intubation injuries are common in intubated patients. There is weak hoarse cry, mild to moderate respiratory distress. Now coming to the end of the today's lecture, the salient points you have to understand that stridor is an emergency. It has to be identified. Stridor can be inspiratory, expiratory, and biphasic. In adults, carcinoma of larynx is a common cause of stridor. In newborn, laryngomalacia is a common cause of stridor. And in infants, laryngotracheobronchitis and foreign body in airway is the most common cause of stridor. Thank you.